Good afternoon. I'm going to present a study on topography-guided cross-linking and its relationship to cellular biomarkers. Me and none of the co-authors have any financial interest to disclose. Cross-linking is still not 100% complication-free. So the research question we had in our mind was, can we customize the cross-linking? Should the cones in the keratoconic cornea be treated differently? And is there a correlation of outcome of cross-linking to cellular biomarkers? We designed this study and tried to answer each of these questions one by one. Coming to the first arm, why should we customize? Cross-linking is a safe procedure, but it's still not 100% complication-free because it's one-size-fits-all phenomenon. So we looked back into the molecular mechanisms of keratoconus. From this published data, we know that in cones, the cross-linking enzymes are decreased, structural proteins are decreased, and inflammatory mediators are increased. So it is possibly a localized disease. So how do we assess these factors? Since these factors are secreted into the tear and epithelium, this can be good biological samples to assess the homeostasis of the cornea. Also from imaging advances like brilliomicroscopy, we know that cone behaves differently than the peripheral cornea. Their biomechanical profile are different. So from both of these studies, we can conclude that biomechanical profile and molecular signatures both are probably different in the cone area. So customizing the cross-linking and treating selectively the disease zone may avoid complications and minimize the collateral damage. Coming to the methodology of study, for this prospective study, we included a total of 35 patients, out of which 15 underwent standard, KXL2, and 20 patients underwent standard accelerated cross-linking with 9 milliwatts per centimeter square. And we examined all the clinical parameters before surgery and followed them till 1 year. Based on the outcome of flattening, we divided it into optimal and suboptimal. Images were acquired from Pentacan and transported to KXL2 device via a pen drive. Manufacturer recommended sector-based UV beam profile was used and treatment was planned. As a clinician, the most important concern of differential beam is high energy. And this is the schematic diagram of the protocol used in our study. According to this table, you can see that the maximum energy used in zone 1 did not exceed 15 joule per centimeter square. And according to safety guidelines, anything less than 19 is safe. Also, the clinical safety parameters were within normal limits. The specular did not deteriorate, and the biomechanics was stable. We did two-way ANOVA analysis amongst the refractive outcome and type of surgery. The steep keratometry showed significant reduction in the optimal group. 70% of the cases undergoing standard KXL and 80% of patients undergoing KXL2 showed positive outcome. The demarcation line was comparable between both the groups, and the topography was also stable and comparable. Now coming to the third arm, why should we link it to cell biology? It's important because outcomes of cross-linking may be determined by the basal inflammation, collagen, and the cellular components. We performed differential gene analysis from the cone area and the peripheral area. That means while removing the epithelium, the cone was sent separately, and the epithelium from periphery was sent separately. We performed RNA extraction and polymerase chain reaction. The gene expressions showed that LOX, that is a cross-linking enzyme, was upregulated in positive outcome in both the groups. Also, tissue inhibitor of metalloproteinases, BMP7 and collagen 4A followed a similar trend. So coming back to the original question, can we customize the cross-linking? Yes, we can according to the topography. The safety and efficacy results were similar to the standard accelerated cross-linking, and we can link the outcomes to cellular biomarkers. I believe in differential beam cross-linking because according to the clinical knowledge we have now, advanced imaging available, and cellular biology, someday in near future we'll be able to demarcate the cone area better and have better beam profile. So what this study adds new is that customized cross-linking is safe and it's efficacious. We can link the outcome to cell biology, and there is a potential role of screening biomarkers like LOX and collagen 4 in tear because we cannot take the epithelium preoperatively, and it can be predictive of cross-linking outcome. Thank you so much.